We'll start. Thanks everybody for coming. The two Yale Interventional Radiology Grand Rounds. Today is my exceptional honor to introduce Dr. Garcia-Tsao. I think she's internationally known, so everybody knows her, but especially for our junior folks, let me make a few introductions. Dr. Lupe Garcia-Tsao is a professor of medicine, hepatology here at Yale. Has been here for a long time since training in hepatology fellowship here as well. She's also the chief of GI, the gastrointestinal disease at the VA Connecticut Healthcare. She is also the associate. She's also the director of a clinical core of NIH-funded the Liver Center here, Yale Liver Center, which is a tremendous, longest NIH-funded liver center in the country. And also, she is associate editor of Hepatology, probably the best, the well-known, the scientific journal of the hepatology as well. She also was the president of ASLD, which is the largest hepatology association of the world back in 2012. So with all the work that she has done, she has numerous awards to count, but most recently she received the International Recognition Award from ESLD, which is the European counterpart of a Hepatology Association back in 2014, and then also she received the Mentor Education Scholar Award from ASLD back in 2015. So she's widely recognized, particularly in her research work in portal hypertension, the varices and portal hypertension treatments. So it is exceptionally pertinent to all of our work in radiology and interventional radiology. So I'm honored to introduce Dr. Garcia-Tsao. She will discuss management of portal hypertension. Afterwards, we'll discuss one pertinent case afterwards. Thank you.
Thank you. Thank you. Thank you so much, Kerry, for this invitation. I love to be here. I have been here 25 plus years, and in all these years, I have always collaborated with my IR providers, especially Jeff Pollack. You know, we have been collaborating ever since I was, even before that, even when I was here as a fellow. So it's an honor to be giving IR grand rounds, really, on a topic that I love. Now, how do I move this thing? Oh, here we go. Got it. Okay, so I'm going to talk to you about the new things of management of portal hypertension, and new meaning that me and three colleagues, Dr. Abarales, Dr. Bercigotti, and Jaime Bosch, have just submitted the final, we think, revision of the AASLD guidance on portal hypertension. So the status that you'll see, I did not put the reference yet because it's not published yet, and I don't want to, screw up the publication. So anyhow, so the recommendations that you'll see there are in a way from the group plus the AASLD guidelines committee plus the AASLD governing board, because it's been undergoing a lot of revisions. All right. So this is the portal venous system, and this is from Andreas Vesalio's drawing in his 1543, the Humanis Corporis Fabrica, which is on the fabric of the human body. This is it goes from the splenic capillaries all the way to the liver. And any increase in pressure in any portion of this system is portal hypertension. And the most common cause is cirrhosis, and cirrhosis, the problem is inside the liver. So just so we understand the therapy, let's go to the pathogenesis of portal hypertension. So the first thing that happens is an increase in intrahepatic resistance. The architecture of the liver is screwed up. There's fibrosis, there's nodules, and this leads to portal hypertension number one. Now, this increased resistance, we used to think it was all structural, and in fact, the fibrosis, the nodules, accounts for about 70% of that increased resistance. But there's a component that is functional, and that's the one that we have been working on more recently. It's active vasoconstriction inside the liver because there's a deficit in nitric oxide. So normally, when you eat, there's an increase in flow into the system. The endothelial cells synthesize nitric oxide. They dilate so that you accommodate all that increase in flow The cirrhotic liver, this does not happen. So if you increase the flow, those vessels are constricted. They're not going to dilate, all right? So that is the functional component. And then as a result of this portal hypertension, collaterals form. Not, and the collaterals that are important to us are the ones that are located in the esophagus. And in this talk, I'm going to talk more about fundal varices than I usually do, because that's where IR has much more of a role. And you would think these varices would decompress the system. Well, they don't, because at the same time that these collaterals are being formed, there's splanchnic vasodilatation. That is, the vessels, the capillaries that feed the gut are dilated, so there's more flow into the gut, more flow out of the gut, and this maintains the portal hypertensive state. Now, this splanchnic vasodilatation is not only splanchnic, it's also systemic, and it leads to an effective hypovolemia that the baroreceptors feel, and they activate neurohumoral systems, specifically renin, angiotensin, aldosterone, norepinephrine, etc. And this leads to sodium and water retention, a relative hypervolemia. Then you have a hyperdynamic circulatory state with increased cardiac output. This increases the flow even more and maintains the portal hypertensive state. Additionally, this activation of neurohumoral systems, which include norepinephrine, contributes to that vasoconstriction inside the liver. So it's sort of like a vicious cycle. So what therapies do we have and where do they act? Well, the ones that we have been using the most are non-selective beta blockers, NSBB, and of course the ones that we use in the acute setting are triptan and terlipressin. They all act by causing splanchnic vasoconstriction, so that there's a decrease in flow and a decrease in portal pressure. Carvedilol is a special kind of non-selective beta blocker that I'll show you later on that not only acts on flow, but we think also acts on resistance. Then you have structural. We're incredibly excited because now that we have therapies for hepatitis C, we're thinking that some of the patients, the fibrosis is going to go away, or at least some of this architectural distortion is going to go away, so that we will be acting on the structural components by treating the etiology. The functional component, we have, like I said, carvedilol. We also now are using statins, and I'll show you results of one study. Statins seem to improve the endothelial dysfunction and increase nitric oxide synthesis in the endothelial cells in the liver. Then we have TIPS. TIPS is the ultimate therapy because you bypass the site of increased resistance by connecting the portal vein with the systemic vein. And these all act in a way on flow and resistance. Varices are pretty much local therapy, so you have ligation, you put the scope in, you ligate the varix. If you can also not only ligate, but for fundal varices, we can inject glue into the varix, and I'll show you data for this. And you can also inject them from inside the vessel, which is BRTO, or the balloon occluded retrograde transvenous obliteration. And we'll talk about all these therapies, but it's not just like one therapy fits all. We have to, and what we have learned over the years, we used to say, oh, let's just stop bleeding, let's stop the patients from bleeding, that it all has to be taken in the context of the natural history of cirrhosis. Nothing can, you cannot just look at this blindly and not see where the patient is in the natural history. So now we know that at the very least, when we see a patient with cirrhosis, and this applies to everybody here, the first question is this a patient that's compensated or is this a decompensated patient? And they're entirely two distinct populations. And what defines decompensation is the presence of clinically overt complications. The patient is bleeding, the patient has overt ascites, or the patient has overt encephalopathy. And I'm saying they're distinct populations because if you look at the survival, the patient that's compensated, that can look like anybody in this room, they have a median survival that exceeds 12 years as long as they remain compensated. Once they decompensate, that survival goes down to about 2 years. And thinking that this is the lead that the patients wait here to get a liver, that's when one starts thinking about liver transplant. Before that, what we're thinking of is to prevent decompensation. And we also know now the compensated stage is the longest stage, and this is the one that I'm actually the most interested in at this point, because it's the longest stage, and I think there's a lot of granularity inside the compensated stage, and I'll talk a little bit about that. The grossest classification was if you say patients that do not have varices versus those who have varices. They are still compensated. These varices have not bled, but the mortalities are different. They're low, but they're different. The patient without varices has a mortality of about 1%, whereas the patient with varices has a 1-year mortality of 3%. It's still low, but higher, all right? So this is also the way we used to substratify compensated cirrhosis. But in the course of our Timolol study, which I will describe, which was an NIH-funded study, we found that the hepatic venous pressure gradient, and this is what we have done all our research about, is about measuring the hepatic venous pressure gradient, which is a indirect measure of portal pressure, good in Hep C, good for alcoholic cirrhosis, and the normal is 3 to 5. More than 5 is what I use to diagnose cirrhosis these days, all right? But in this study, we could find that the best predictor of developing varices was the baseline HVPG, and we could find 2 subpopulations: those that had mild portal hypertension, where the baseline HVPG was 6 to 10, and those that had significant portal hypertension. So this was in terms of predicting development of varices. But we since then have found that this same cutoff of more or equal to 10, which is clinically significant portal hypertension, not only predicts the development of varices, but also predicts who's going to decompensate, who's going to develop HCC, and who is going to develop complications, mainly decompensation post-liver resection for cancer. There's all studies that support all these contentions. Now, by definition, a patient who has developed varices, they have already reached that threshold of 10 for sure, at least 12 at least, and have by definition clinically significant portal hypertension. So now we are at the stage, and this is in the new guidance, where compensated cirrhosis, now the main subclassification is into mild portal hypertension, HVPG greater than 5 but less than 10. They have portal hypertension, but it's mild. And the clinically significant portal hypertension, which is an HVPG greater or equal to 10. And within this category, patients may or may not have varices. Then in the decompensated patients, we have to understand that variceal hemorrhage is one of the decompensating events, but this patient may or may not have ascites and encephalopathy. So far, like I said, we have been concentrated on varices, no varices bleeding, but we forget that the patient may have other decompensating events, and the bleeding in a compensated patient has different prognostic and therapeutic implications than bleeding in a patient that's decompensated. And I have a stage that I describe as further decompensation, where the patient bleeds again, but again, these patients are more likely to have ascites, and not only more ascites, but they are more likely to have refractory ascites, hyponatremia, hepatorenal syndrome, recurrent encephalopathy, and jaundice. So these patients are clearly near to death. And so now in our new guidance, we're saying that the management of varices has to be considered in the context of the other complications. So that what is our objective? This we have not a lot, because we just defined mild portal hypertension. In the patients with mild portal hypertension, which is a super compensated patient, our objective is to prevent them from developing clinically significant portal hypertension. And here we want to target the intrahepatic mechanism, treatment of etiology. That's where we're treating hepatitis C, improving endothelial dysfunction, antifibrotics, if they ever work, that's where we're going to target that. I don't have any data for this. In patients with CSPH who do not have varices, our objective is to prevent varices, and that's what our Timolol study was about, as I'll show you in a second. But we forget that these patients are also at risk of decompensation, so in every trial what we also want to do is prevent decompensation and use strategies that have the potential of preventing decompensation. This is our Timolol trial. This was an NIH-funded multi-center study where patients at the outset had cirrhosis, had an HVPG at least more than 5, and did not have varices. And the objective was to see if with beta blockers we could prevent the development of varices. As you can see here, after 10 years of hard work, the study was negative. So we could not find it. And this is odd, because we said, oh wow, this was a very homogeneous group of patients. This should have worked. And I lost my train of thought. So anyway, so we thought, why did this not work? So bottom line, the recommendation is that at this time there's no recommendation to use beta blockers to prevent the formation of varices. From this study, it was a negative study. But we went to analyze, and that's where we found out that we had patients with mild and clinically significant portal hypertension. So we looked at the response to beta blockers in these patients. And think about it. Beta blockers are acting in increased flow, okay? So they have the beta-1 effect, which is decreases cardiac output, and the beta-2 effect that acts causing splanchnic vasoconstriction. In fact, this latter effect, the beta-2 blockade, is a much more potent effect. That's why heart rate decrease does not correlate with decreases in portal pressure, because the ones that were measured with heart rate is the beta-1 blockade. And we cannot measure the beta-2 blockade other than measuring portal pressure, which we are not recommending. So non-selective beta blockers, Timolol, which is what we use in that trial, act in the increased flow. And so the issue is maybe we're taking these patients too early on, and the mechanism was still resistance, and these patients did not have an increased flow yet. And in fact, that was the case. When we looked at patients with mild versus clinically significant portal hypertension, we saw that the changes in HVPG in these patients was 0. They did not respond to beta blockers, and these were about, half of the patients roughly. And those with clinically significant portal hypertension did respond to beta blockers, so that patients with mild portal hypertension is not only, that they predict things happening, but in these cases, these patients have, the main mechanism is an increase in intrahepatic resistance, whereas in these patients, there's resistance and flow, and beta blockers are going to work in this setting. And this has been recently confirmed by Villanueva and colleagues in Barcelona, where they looked, again, mild versus clinically significant in a larger number of patients. And again, the response to beta blockers, this was IV propranolol, was significantly greater in those with clinically significant portal hypertension. And these patients actually had a higher cardiac index compared to those that had a normal cardiac index. In the study that I did last year when I was on trying to leave in Italy, where they float the Swan. Actually, they do the HVPG and everything with the Swan catheter. So we have cardiac index measured by Swan, and we could stratify the patients. These are all compensated patients, and you can see here how in the mild portal hypertension, the mean arterial pressure and the cardiac index are normal. And this jump from mild to clinically significant has a huge increase in cardiac index and a decrease, and more so in those with varices, and a decrease in mean arterial pressure. And so we think that even there's a lot of granularity even between here and here, but clearly these patients have a normal cardiac index and mean arterial pressure, and drugs that act on flow will not work, like we showed in the Timolol study. So even in the Timolol study, we could find that those that decreased the HVPG by greater than 10% at 1 year had a lower probability of developing varices than those that did reduce the HVPG. So if we had more patients in the clinically significant portal hypertension group, we would probably have found positive results in the Timolol study, but it's hard to say at this point. Now, what about patients who have varices? This is where we have most of the evidence. Can we prevent variceal hemorrhage? But not to forget, not only do we want to prevent variceal hemorrhage, but we want to prevent other complications of cirrhosis such as ascites and hepatic encephalopathy. So this is where we first stratify patients. Who are the patients that are at a higher risk of bleeding? And these are patients that have medium to large varices, that have any size varices with red wale marks, and those that are present in a child seat patients. If these patients have not bled, these are all candidates for primary prophylactic therapy to prevent that first episode of variceal hemorrhage. And can we do this non-invasively? Well, in Baveno, there was this, based on a lot of studies, and in a large study, which is sort of a meta-analysis, a liver stiffness by transient LSRV less than 20 and a platelet count more than 150K predicts who is unlikely to have high-risk varices, and then you can avoid endoscopy in these patients. With Dr. Janguk, who's here, we did a validation study. We found that in fact none of our patients that had these characteristics had high-risk varices. And then again in Baveno, which was last year, this is a consensus conference among people who work on portal hypertension. We set up the data of when to repeat the endoscopy, and now we did it based on whether the liver injury is ongoing or whether the liver injury is quiescent. For example, when we eliminate hepatitis C virus, we have to lengthen the periods where we screen for varices. Now, we do have two treatments that reduce the risk of varices. For many, many years, all we used were beta blockers, and this was based on meta-analysis of a lot of randomized controlled trials, where you can see here that the risk of first hemorrhage was significantly lower on those on beta blockers with a tendency of a decreased mortality. But then ligation came around, okay, and endoscopies love ligation, all right? And in fact, this meta-analysis from the Cochrane group showed that ligation had a lower risk of first variceal hemorrhage than beta blockers. Now note that the group on beta blockers, the risk at about 2 years is 20%, whereas it was 14% in the randomized controlled trial. So many of these trials, patients may not have been taking beta blockers properly and so forth. And when they did a sub-analysis of good quality trials, which were 7, they could find no differences in bleeding between ligation and beta blockers. So bottom line, the recommendation is that we should use beta blockers or ligation, as I'll show you in a second. Now, what is the beauty of beta blockers is that it acts on the pathophysiology. Ligation is a local therapy, right? So as you would expect, those patients in whom the HVPG goes down bleed less, but importantly, they also die less. Okay, so that's the bottom line. We're here to save lives, and beta blockers give you the possibility of improving survival. And in fact, responders, why do they survive more? Because responders also had a lower probability of developing ascites. So when you act on the pathophysiological mechanism, you're going to have results that go beyond variceal hemorrhage. You can prevent the other complications of cirrhosis. Now, about 30 to 35% of patients on non-selective beta blockers actually are responders, all right? So how do we enhance that rate of responders? And one of the ways is to do carvedilol. Carvedilol has a double effect. It decreases flow, but it has an alpha-1 blockade component that should act on the increased resistance. And so in proof of concept studies, this is the response rate with non-selective beta blockers. This is the response rate with carvedilol. So that's higher response rate. But when they used doses that were like 25 to 30 milligrams a day, and they were all associated with decreases in MAP and fluid retention. So that's not good. So for many years, no one did carvedilol anymore until the UK said, well, let's use a lower dose. Let's use 12.5 milligrams a day maximum. And they compared it to ligation, and they found that the rate of first variceal hemorrhage was significantly lower with carvedilol compared to ligation. So now going back to shunt therapy. So, and this relates to tips. We don't do shunt therapy, surgical shunts, we don't do them anymore. But this was the data from way back regarding whether we should use tips or shunt therapy. And you can see here that clearly the shunt was the best in preventing rebleeding, no question about it in our minds, but at the risk of higher encephalopathy and a higher mortality. Therefore, in the patient that's compensated, has never bled, one should not use shunt therapy. It's not recommended. So these are our recommendations. For a patient who has medium to large, the high-risk varices that have not bled, it's non-selective beta blockers, the traditional ones, or carvedilol or ligation, one of the three. Patients on non-selective beta blockers or carvedilol do not require any more endoscopies, and we do not recommend, and this is based on one trial, therapy with combined non-selective beta blockers plus ligation. And TIPS placement is not recommended in this setting, in the setting of primary prophylaxis. Now, let's go to fundal varices. Like I said, I usually don't talk about this. The risk is about 15% per year, which is comparable to esophageal varices. And you can see it here. And the predictors are exactly the same as for esophageal varices. The size, the child class, and the presence or not of red whale marks, same exactly. The mortality seems to be much higher, however, in those with fundal varices. 48% were dead at 1 year. The thing about this study is that it's done in Korea, and 40% or actually more develop HCC throughout time. So this mortality is not entirely due to the varices, but due to HCC. There's one single randomized trial of glue versus propranolol versus observation only in patients with large fundal varices. This is from India. Doing a 3-arm trial with only 30 patients in each arm is clearly underpowered. The rates of bleeding on propranolol and no therapy were much higher than ever reported in the literature, and they conclude that glue is what you should do. However, it's underpowered, and we have all concluded that larger studies are necessary before this is recommended. Now, there is one non-randomized, very small study that compared BRTO in observation in patients with fundal varices who had never bled, and bleeding was lower with BRTO, and death had a tendency also to be lower with BRTO. But again, this is a non-randomized, very small trial, only 17 patients in each group, so we cannot put any weight to this. So larger studies are needed before any formal recommendation can be made regarding anything. In fact, you can go out there and not give the patient any therapy and you would not be criticized for this. We can use non-selective beta blockers, but the data is not as strong as that we have for esophageal varices, and neither TIPS nor BRTO are recommended at this point in this setting. Now, what about the patient who bleeds? Okay, the issue with the patient who bleeds, we have to stop the bleeding, and we have to decrease recurrent variceal hemorrhage and thereby death. But always remember that they may or may not have other complications. And we have been very successful over the years in improving survival in patients who have bled from varices. And this is already an old study, but the mortality has been decreasing progressively. In this study, the decrease in mortality was ascribed to using prophylactic antibiotics, which are now standard of care, intravenous vasopressors, and ligation as opposed to sclerotherapy, all right? But there's two advances since then that have improved survival even further. One of them is this issue of restrictive transfusion strategy. So clearly, this is a study that looked at all GI bleeders, but I'm just showing you the data of patients with cirrhosis. And you can imagine that if a patient comes in, they've bled, the blood pressure goes down, the flow through the varices goes down, they bleed less. You tank them up, that thing is going to bleed again. And in fact, what they did is they randomized patients to a restrictive transfusion strategy, is when you start transfusing at 7, okay, not higher than 7, but 7, and you maintain the hemoglobin around 8. Versus liberal strategy, which was they started transfusion when the hemoglobin hit 9, and they kept the hemoglobin around 10. And you can see here, these are all patients with cirrhosis. Overall, this is survival. There was a better survival with restricted transfusion strategy. It is mostly applied to child A and B patients. In a subset of these patients, they actually measured the HVPG, and in these patients, the HVPG did not change, whereas in those with the liberal strategy, the HVPG went up, which had already been shown in experimental animals. You give them back their blood, and they're going to rebleed. So this was in our previous guidelines. This is from 2007, so we're now finally getting the new ones out. We have a variceal hemorrhage, we resuscitate, we maintain the hemoglobin around 8, we give antibiotic prophylaxis, we use a safe vasoactive drug, the only one we have here is octreotide, we do an endoscopy within 12 hours, and if it's confirmed that it's from esophageal varices, and now I'm talking about esophageal varices, we do ligation. Actually, the new guidance doesn't even talk about sclerotherapy anymore because no one does sclerotherapy. And then we continue drugs and antibiotics, and it fails this standard of care, then they go to TIPS. So in the usual standard of care, TIPS was a salvage therapy. Who are the patients that are most likely to fail? These are the child C patients. In every study you can look at, child C are the patients with the worst prognosis, the patients that are the most likely to fail. So these investigators in Europe thought, well, what if we put a TIPS in before the patient fails? This is in child C patients. So that we choose the high-risk patients, we put a preemptive TIPS before they fail. This is the rationale behind the early TIPS study. These were 60, this is not a huge study, 63 patients, 90% were child C, 10 to 13 points, so not the sickest. The 14 and 15 points they excluded, or they were child B with active bleeding. And they put in a TIPS within 72 hours. Most of them had in between 24 and 48 hours. The 72 hours were like a couple of patients. And they followed them for 16 months. And you can see here that the results are pretty amazing. There was only one patient in whom bleeding failed to be controlled, and this was because the portal systemic gradient could not be reduced under 12, versus 14 in the standard therapy group. And the death rate, which is the most impressive thing, was significant. These are all child C patients mostly, was 12% versus 39% without differences in encephalopathy. So this is something new that saved lives. Now note, this is not for all patients. There's only 18% of their admissions with variceal hemorrhage met the criteria for inclusion in this study, right? So patients who were very sick, who had who are not candidates for TIPS obviously did not go for TIPS. So this is a new standard of care. We stratify. We start the same way. We do the ligation. If it's a not high-risk patient, they continue the vasoactive drug. If it's a high-risk patient, it's mostly child C, then early TIPS, ideally within 24 hours, must be considered in selected patients that are a candidate for TIPS. And we obviously restrict, if these patients fail, then they go for rescue TIPS. So the key here is to prevent recurrent variceal hemorrhage. But in the process of preventing recurrent variceal hemorrhage, we have to always remember what is happening to the other complications of cirrhosis. And this is the story of what we've done. These are all randomized controlled trials. There's been a huge amount of evidence in terms of prevention of rebleeding. And over the years, so if you don't do it, these are the control groups of these randomized controlled trials. If untreated, a patient who has bled has 60% chance of bleeding again in 1 year, which is significantly lower than the first bleed rate, which is around 15% per year, right? So here, clearly the anxiety level is much higher. You're going to be more aggressive, all right? And so over the years, we start with non-selective beta blockers, sclerotherapy. Bottom line is the combination. This is where you use the combination because you're going to be much more aggressive, ligation and drugs. And the data that supports this is, again, a lot of trials. This is the meta-analysis that looked at these trials. And I'm going to show you here, the upper panel is the trials that compared non-selective beta blockers versus combination therapy. So essentially, we're seeing what happens when you add ligation, all right? And when you see here, really, none of these are significantly different. Whereas when we look at the other lower panel is when you use ligation as the control group and you're exploring what happens when you add non-selective beta blockers. In this case, clearly, there's a significant reduction in all-cause rebleeding with the combination therapy. And there's also a tendency for lower mortality in the combination therapy. Now, all these trials, think about it, we used to lump every patient with cirrhosis in the same category. They've bled, we want to prevent rebleeding, whether they're compensated or decompensated, we don't care. So we are now into the era of stratifying patients and figuring out, are these therapies good for every patient, or is it different for the compensated or the decompensated patient? So because of this, we asked the authors of these papers and some others to give us the individual data. And this is totally unpublished data. We just submitted the manuscript. And so we stratify them. So these are the overall results. And we stratify them by child A, which is the mostly compensated patients, versus child BC. And you can see here, the upper panel is when we add ligation to non-selective beta blockers. Overall, there's no effect. By child, there seems to be that the child A patients, there's lower rebleeding. So the added effect of ligation is marginal at best, all right? The combo seems to prevent rebleeding in child A patients, as you see here. And the interaction, there was a difference between child A and child BC patients, at least for rebleeding, so the interaction was positive. Now, on the other hand, when you add non-selective beta blockers to ligation, you see clearly overall an improvement in survival and a reduction in rebleeding, all right? And again, child A seemed to benefit the most. So I'm sorry, child BC seemed to benefit the most. Look here, these are child BC patients. So the added effect of non-selective beta blockers leads to less rebleeding and death, particularly in child BC patients. So in those patients, you need the combination therapy, and they need to have the non-selective beta blocker. Because we did this individual meta-analysis, we could look at survival curves, because we knew that the time to event. So you can see here that in the upper panel is when you add the ligation, no differences in survival, child A or child BC. But when we add beta blockers to the ligation, there's a difference in survival in the child BC patient with a lower mortality in those that have the beta blocker versus those who are left on ligation alone. So bottom line, and these are the patients that are more likely to have ascites and refractory ascites. So it's incredibly important that these patients are not left on the ligation alone. They have to have the beta blocker. So the key element of combination therapy, particularly in child BC patients, is the beta blocker. And why Are patients on beta blocker having a lower mortality? Because not only do responders have less bleeding, but they also have less death. All right, and this is due to the fact that responders also have a lower incidence of other complications of cirrhosis, such as ascites, spontaneous bacterial peritonitis, and hepatic encephalopathy. So the recommendation is that the first-line therapy for all patients is a combination of non-selective beta blockers plus ligation. Non-selective beta blockers is the key element of combination therapy, and carvedilol has not been tested in any trials of secondary prophylaxis, so therefore that's why it is not recommended as secondary prophylaxis. And the people we concluded this in the Baveno conference, and the authors that had worked with carvedilol were very upset. But the fact of life is we rely on the evidence of whatever is out there. Now, there's been a lot of controversy about non-selective beta blockers leading to a higher mortality in patients with refractory ascites. There's a lot of evidence now against this fact, but the recommendations are the following. In patients with ascites, these beta blockers should be used cautiously because they're more likely to get hypotensive, and you do not want them to get hypotensive. So we limit the dose to 80 milligrams, BID for propranolol or QD for nadolol. And if the patient's blood pressure goes down, they develop hyponatremia or acute kidney injury, that's when we reduce or discontinue the dose of non-selective beta blockers. The problem with this paper was that people were discontinuing beta blockers right and left, even in those on secondary prophylaxis, and like I just showed you, this is a dangerous thing to do. Now, how can we enhance responders more? Statins, remember statins I told you act inside the liver by decreasing resistance. So this is a trial that at the outset they were all patients that had bled, that were on ligation and non-selective beta blockers, and they got randomized to simvastatin, 40 milligrams a day versus placebo. And you can see here that even though rebleeding was not different, survival was significantly better with simvastatin. And this may be because there's an improvement in function. As you dilate the intrahepatic circulation, there's more flow towards the liver. And we'll talk about this a little bit. And therefore, that may be why patient survival. Now, they do not develop hepatotoxicity, but two patients did develop symptomatic rhabdomyolysis. So this is something I won't have to be aware of, especially in patients who are jaundice. Now, what is the place of tips in prevention of recurrent bleeding? Clearly, it's more effective than combination therapy in terms of rebleeding, but without differences in survival or without differences in treatment failure, but there's higher encephalopathy rates in those patients on tips. Therefore, that's why it's relegated in a way to a second-line therapy. So in whom do we use tips for secondary prophylaxis? We use them in patients who rebleed despite non-selective beta blockers and ligation. This is not a recommendation. Okay? We suggest this in the guidance. We don't recommend it. Patients who cannot tolerate non-selective beta blockers or become really hypotensive and are going to be left on ligation alone, I would rather send them to tips than leave them on the ligation alone. And the other unexplored group who have always been excluded from randomized trials are patients who bleed despite being on primary prophylaxis with non-selective beta blockers or ligation. So if they bleed despite this, one should think that maybe they should go to tips directly. But these are, again, just suggestions, not a recommendation. The only recommendation is the first one. Now let's talk about treating acute bleeding from fundal varices and preventing recurrent hemorrhage. These are different things. When they rupture, they do it through the muscularis, mucosa, and laminar propria. Most of them that bleed are big. And to do ligation in this setting actually can be dangerous because they can necrose and cause major bleeding. Only the small ones can be done with ligation. And what has come here is that we cannot do a rubber band, so why don't we inject glue? So they inject cyanoacrylate glue into the varix. This is a huge varix, and they get hardened inside the varix itself. And so there's not a lot of evidence. As in anything that I show you for fundal varices, we have very little evidence. There's 3 trials, actually, this is like the most we have, all right, that looked at glue versus ligation in acute gastric variceal hemorrhage, and many of them including GOV1s, not fundal, but the ones that are like extending from the lesser curvature to the stomach, which should be treated like esophageal varices. So when they compare glue and band ligations, there's no difference in terms of control of hemorrhage, but there is a benefit with glue in terms of less rebleeding. So no one is really recommending band ligation for glue. So how does glue do in front of tips, for example, which is, in my mind, where if you cannot do glue, you have to go directly for tips. You can see here that in this data shows that with tips, there was clearly less rebleeding from gastric varices with no differences in survival. Problem with this study is that, well, this is not a problem. They all got cyanoacrylate to control the active hemorrhage. So that, by definition, they all got cyanoacrylate, and then they got randomized to tips or continued cyanoacrylate. And half of the patients were GOV1 non-fundal varices. So these were gastric varices that were not in the fundus. So again, not incredibly strong evidence. The numbers were not high. So how can we, otherwise, how can we, this was a very creative thing, how can we, in a way, sclerose the varices from inside the vessel? And this is the concept behind BRTO, which is balloon-occluded retrograde transvenous obliteration. This audience knows this perfectly well. And you can inject then the sclerosant from inside the vessel, not endoscopically, from inside the vessel. So these are patients that by definition have to have large gastro or splenorenal shunts, because you're going to go through the shunt, you put a balloon there, you inject sclerosant, and so you're sclerosing the fundal varices from inside. There are different variants where you use a plug as opposed to a balloon, or use coils instead of a balloon, but the bottom line is you're sclerosing from inside the vessel. Unfortunately, there's not a lot of data on this, but it's sort of cool. Think about it. If you think about it, we're talking about flow. When you do a tip, so you're connecting this vein with the systemic vein, the flow is entirely bypassing the liver. You're decompressing the whole system, all the varices, you're decompressing everything, but the flow is now not going to the liver, it's going through the shunt, all right? With BRTO, you are occluding a huge collateral. All right, so this, in a way, was decompressing the system. Not entirely, but it was decompressing. You occlude this collateral, so now the pressure is going to increase, but the flow to the liver also increases. All right, so the mechanisms are entirely different. So when you compare BRTO versus TIPS, the mechanism BRTO, you're obliterating the varix from inside the vessel. With TIPS, you're decompressing the portal system. Some people say that, that reducing the pressure in patients with fundal varices is not as effective, that you have to reduce as much more because the varices are more distal. They're coming off of the splenic vein. The portal pressure increases, and some studies show that this is just a transient increase, which TIPS it clearly decreases. The flow to the liver increases, which is a good thing. And as a result of this increase to the liver with BRTO, there's an improvement that may or may not be transient on liver dysfunction. With TIPS, the flow to liver is entirely prevented, and this is a bad thing. Because flow to the liver pressure is increasing, you have the risk of worsening ascites in those who have ascites, whereas in TIPS it improves it. Encephalopathy may also improve with BRTO because you're improving flow to the liver, whereas it clearly may worsen with TIPS. Liver dysfunction, as I mentioned, improves with BRTO and may worsen with TIPS. And the problem is, as you're closing that collateral, the patient has esophageal varices, they're going to grow and bleed. Whereas in this case, esophageal varices are taken care of. So there are, and I think there's a place for this. The problem is that no randomized trials have compared BRTO with other therapies, call it glue or TIPS or anything, there's no randomized trials. And I think that one should have some kind of algorithm. We cannot have a randomized trial, at least to have some kind of algorithm by which we say, this patient is fairly compensated, or this patient has ascites and large esophageal varices, we have to be cautious about placing a BRTO. So it has to have a conversation between the interventional radiologist and the clinician to figure out who is this patient, where is this patient in natural history, and what is the procedure that's going to benefit the patient most. And some sites are doing the following, if the patient has a huge esophageal varices and you do a BRTO and the HVPG goes up a lot, maybe you put the TIPS at the same time. So, but this all requires sitting down and having a discussion, going down to IR and discussing this with the interventional radiologist. So this is sort of the algorithm that we're recommending. So the beginning is exactly the same for esophageal varices. You resuscitate the patient, you give antibiotic prophylaxis, you use a safe vasoactive drug, you do the endoscopy, you find that it's fundal hemorrhage, and first of all, panic arises, right? The recommendations, the strength of the evidence is for glue or tips. And this was a major fight with the AASLD because we wanted to recommend cyanoacrylate glue as the first one, but most centers in the US do not do cyanoacrylate glue. So now we say one or the other are acceptable as first-line therapies. Tips, particularly if there's no expertise for glue. Now, if the patient got glue and bleeding is not controlled with glue, then you go to tips, and most of them do embolization of the collaterals at the same time. If the patient started with tips and is not controlled with tips, or the patient is not a candidate for tips, or if this fails as well, then the patient should go for BRTO. This was not a recommendation. This is something that we put in the text because we cannot formally recommend this, but this is the algorithm that was at the end recommended. So, in summary, what I've shown you is that when we manage varices and variceal hemorrhage, we have to think, who is our patient? Where is the patient in natural history? What is the severity of portal hypertension? And does the patient have or not have other complications? I've shown you that advances in the therapy have resulted in lower rates of decompensation and death, particularly for therapies that act on the pathophysiology of portal hypertension. Randomized trials in patients with fundal varices are needed. And even in these patients and in any other patient, we need to stratify risk and improve therapies that are individualized to the specific patient with cirrhosis. Thank you for your attention.